topic for discussion today is tuberculosis. As we all know, tuberculosis is one of the most increased or most commonly encountered disease. It is with increased incidence, especially in patients with HIV, and also it is known to have a predicted spread of this tuberculosis. Normally, tuberculosis is usually caused because of Mycobacterium tuberculosis, and other causative organisms include Mycobacterium bovis, Mycobacterium avium, and Mycobacterium kansasi, xenopi, and malmoense is also one of the most common causes of this, the causative organism for the spread of tuberculosis. Normally, there is something called as MAIS complex, which is a combination of Mycobacterium avium with intracellular and Staphylococcus. This is also one of the causative etiology for tuberculosis. Now, coming to Mycobacterium tuberculosis, it is usually a rod-shaped bacteria which is a causative, and this is a picture shows a Mycobacterium tuberculosis here. Normally, the risk factors for this is usually seen in children, young adolescents and adults, and patients who are in close contact with the patients with tuberculosis. It can be healthcare workers, it can be any underprivileged people who are living in unsanitized or in very crowded areas, in the places where they are overcrowdedly living and increased density of population. Patients who are immune compromised in those cases, and patients with systemic conditions such as diabetes mellitus, alcoholism, any gastric surgery, all these factors are risk factors for tuberculosis. When it is coming to pathogenesis, normally Mycobacterium bovis spreads through non-sterilized milk from infected cows. Cows which have been infected with tuberculosis, their milk can spread Mycobacterium bovis. Mycobacterium tuberculosis is through droplet infection, and hence it is usually seen in patients who have been closely associated with patients already affected with tuberculosis. In those cases also, through droplet infection or through saliva contamination from one patient to another patient, this can spread. On inhalation, what happens is, when through droplet infection, we are telling that Mycobacterium tuberculosis spreads. So what happens? What is the process that is actually taking place there? When a patient coughs, then the droplet infection is being attacked, the droplet is been attacked onto the other person. So these organisms will enter into the airway and they settle down in the alveoli. Within the alveoli, they recruit lymphocytes and macrophages, and they transform into Langerhans cells and epithelioids. These club with lymphocytes again. The whole entity is now called as tuberculous granuloma. This will actually decrease the alveolar space there. So here is a picture, a histopathological slide which is showing pulmonary tuberculosis and non-necrotizing granuloma within it. These granulomas, what they do, they aggregate to form a primary lesion, also called as Ghon's complex or Ghon's focus, in the peripheral lung, and these later split into hilar lymph nodes. Ghon's focus is a pale yellow color caseous nodule which is usually a few millimeters to 1.2 centimeters in size. This one, the primary lesion, and along with involvement of regional lymph nodes, is called as primary complex of Rank. So primary complex of Rank is nothing but primary lesion and associated lymph nodes that have been involved. The whole entity is now called as primary complex of Rank. So now we have come across two important things, that is Ghon's complex, Ghon's focus, and primary complex of Rank. So what is latent TB? Latent TB is actually a reparative process which will lead to fibrous capsule around the primary capsule. In those conditions, it is actually one of the thing that has been there, where most of the people who have been infected through this droplet infection will have latent TB than active TB. Whenever they have an immune compromised stage, then this latent TB activates, then giving rise to active TB. Normally, in this latent TB, when the fibrous capsule which is surrounding the primary capsule, this lesion usually calcifies eventually, and this can be seen on a chest X-ray as calcifications or radiopacities along the chest. So this is a latent TB, and seeding of the secondary foci into other organs can also be seen in this condition. Coming to the clinical features of tuberculosis. Tuberculosis can have various systemic manifestations and primarily include cough. Patients' initial lesions in the primary pulmonary tuberculosis may have dry cough, but later in established pulmonary tuberculosis they can have cough with expectorant, that is a sputum. and they'll have poor appetite, night sweats, high rest and fever, lymphadenopathy can be seen. Patients usually complain of weight loss. They have gastrointestinal symptoms such as anorexia, vomiting sensation, chest pain, that is tuberculous pleuritis can be seen, where patients will have chest pain, and extra pulmonary tuberculosis can be seen, where the most common sites are meninges, lymph nodes, bone and joint sites, and genitourinary tract. These are all the extrapulmonary tuberculosis sites are seen. Normally, in the written of dormant tuberculosis, what happens is there will be cough with increasing mucus and also coughing up of blood can be seen. Now coming to primary tuberculosis, excuse me, in the infection stage where it's about 4 to 8 weeks period of time, usually we can see the primary complex, then later there will be skin test conversion and influenza-like illness can be seen. Normally, when the disease is actually manifested, then various systemic symptoms include, there will be lymphadenopathy can be seen, collapse of or consolidation, especially the right middle lobe of lung, and miliary tuberculosis, meningitis can be seen, pericarditis, pleural effusion can be seen in these cases with cavitation and obstructive emphysema. These are various conditions within during the disease process. Here is a picture which we can see cavitation in pulmonary tuberculosis, and there will also be hypersensitivity reactions, especially dactylitis, erythema nodosum can be seen, and also you can also see conjunctivitis in these cases. And coming to primary pulmonary tuberculosis, in the primary TB infection, what happens is it is an infection in the individual who is previously uninfected. So primary tuberculosis will occur only in patients who are uninfected. So it doesn't have anything related to latent tuberculosis. Usually it is a self-limiting in nature. Self-limiting febrile illness will be seen in this condition, and clinical illness occurs if the hypersensitivity reaction is seen. Mostly main symptoms of pulmonary tuberculosis is appetite loss, there will be fatigue, there will be chest pain, coughing, up of blood, prolactive and prolonged cough can be seen, night sweats and pallor can be seen. Coming to miliary tuberculosis, here it is an extrapulmonary site where spread is through hematogenous dissemination. Patients usually present with an acute manifestations. It is characterized by 2 to 3 weeks of fever, dry cough, there will be weight loss, there will be anorexia and also night sweats. And there will be enlarged liver and spleen which is tender. Patients will also have headache. If patients are complaining of continuous headache, then suspicion of tuberculous meningitis also have to be done, along with other symptoms such as stiffness of neck, etc. On auscultation, what happens is it is normal, but in advanced cases, what happens is we usually hear widespread crackle sounds. Fundoscopy can also be done in these cases, and they can see choroidal tuberculosis in this case. Anemia and leukopenia are common blood investigative features, and cryptic miliary tubercle in old age group is seen. It is usually an unusual presentation. And chest X-ray usually shows a millet seed appearance in these cases. Well, we see small radio-opaque opacifications can be seen. Radio-opaque opacifications can be seen on the lung, on the radiograph. Even on the cross section also you can see this calcification. And when we see them, they appear as millets. Hence they are called as millet seed appearance can be seen on the chest X-ray. Now coming to cryptic TB. Usually seen in older age group of more than 60 years of age, and if they have low grade intermittent pyrexia can be seen in these cases. Weight loss, general debility and enlarged liver and spleen, again hepatosplenomegaly are most common conditions here. Here we can see the chest X-ray. Usually it is normal. Chest X-ray is normal. There will be negative tuberculin skin test, but the symptoms are all similar to that of tuberculosis. Pancytopenia and leukemoid reaction can be seen. Biopsy and acid-fast staining are usually helpful with diagnosis. Now coming to post-primary pulmonary tuberculosis, it is usually insidious in origin, and this post-primary pulmonary tuberculosis are of two different types. One is exogenous type, where it is a new infection, and endogenous, which is nothing but reactivation of a dormant primary lesion. So this is post-primary pulmonary tuberculosis. In this usually the pulmonary condition, apex of upper lobe is involved in these cases. Patients will have fever, malaise, night sweats, they will be having chills, weight loss and loss of appetite. Chronic cough can be seen. This chronic cough can lead to hemoptysis, that is nothing but coughing off of blood. Unresolved pneumonia can be seen. There will be exudative pleural effusion also. And there will be spontaneous pneumothorax also in these cases. Coming to the chronic complications of pulmonary tuberculosis, there are pulmonary and non-pulmonary complications. When it comes to pulmonary complications, it can have massive hemoptysis, cor pulmonale, it can have fibrosis, emphysema, cavitation, atypical mycobacterial infections, Calcifications can be seen, aspergilloma, and obstructive airway disease or bronchiectasis can be seen. Now when coming to non-pulmonary signs, there will be laryngitis. You can see amyloidosis in these cases, anorectal diseases, enteritis, Pons-X polyarthritis, and empyema necessitans is also one of the non-pulmonary complications associated with that of tuberculosis. Coming to radiological examination, usually radiological examination can reveal ill-defined opacifications on both lobes or one upper lobe, one or both the upper lobes. There can be consolidation, there can be collapse and cavitation. Coming to radiographic examination, usually radiographic examination alone may not be useful in differentiating whether it is an active, that is miliary type pattern and cavitation, or a quiescence disease. So quiescence disease, that is a dormant disease. So whether to differentiate between an active or dormant condition, a radiographic examination alone may not be helpful. In such cases, what we can do is, we can go for sputum examination. In extensive disease, what happens? There will be collapse with displacement of trachea and mediastinum. There will be collapse of trachea and mediastinum in extensive diseases. Sometimes a caseous lymph node will drain to adjacent bronchus, resulting in tuberculous pneumonia. Coming to extrapulmonary disease, usually it occurs in 20% of patients with HIV negative, and mostly in HIV positive patients, extrapulmonary disease can be seen. Here lymphadenitis is one of the most common feature. There will be enlargement of lymph nodes. Usually initially there will be many multiple lymph nodes enlargement which are discrete, which later become matted. Most common extrapulmonary site of disease is lymph nodes, that is lymphadenitis. Usually cervical lymph nodes are most commonly involved, then mediastinal lymph nodes are most commonly involved, then axillary and inguinal lymph nodes are the other lymph nodes which are commonly involved. It can be either a primary infection or it can also be a contagious reactivation also. Coming to mediastinal disease, which leads to supraclavicular lymphadenopathy, and these nodes are usually painless, they are mobile and later they become matted. With caseation and liquefaction, what happens is these nodes usually swell, they become fluctuant and they burst, and they discharge through the skin, giving up to a collar stud abscess. Okay, this is a pathognomic feature of collar stud abscess is one of the pathognomic feature of tuberculosis, and that is also extrapulmonary tuberculosis affecting lymph nodes. It usually may not be associated with other constitutional symptoms. Tuberculin test is strongly positive in these conditions, and rarely surgical excision is required in case of lymphadenitis. Underlying tuberculosis drugs can be helpful in reducing the lymphadenitis also. Coming to gastrointestinal tuberculosis, it can affect any part of the bowel, and upper GIT involvement is usually rare, and in any unexpected, usually rare, and it is usually encountered as an unexpected histological finding in case of an endoscopic or laparoscopic finding. Normally, the ultrasonographic and CT findings will show a bowel wall and mesenteric thickening. There will be abnormal lymphadenopathy, and ascites can also be seen in these cases. Barium meal swallow and small bowel enema will show us the conditions like narrowing and shortening and distortion of the bowel, and there will be cecal involvement also. A diagnosis for this is through mini laparotomy or colonoscopy. Most commonly, this disease has a close resemblance to Crohn's disease, and hence the differential diagnosis can be Crohn's disease, and all diagnostic criteria required to eliminate Crohn's disease also have to be done. Coming to tuberculous peritonitis, there we can see abdominal distension, pain and constitutional symptoms. Ascitic fluid is present, which is usually exudative, and we can also see number of lymphocytes in this ascitic fluid. There will be low-grade hepatic dysfunction in miliary tuberculosis, and patients usually can be icteric. Now coming to pericardial disease. In this pericardial disease, there will be pericardial effusion and constrictive pericarditis. Insidious presentation, it is usually a slow and progressive presentation here, and they can have breathlessness and abdominal swelling also. Pulsus paradoxus, raised jugulovenous pressure, hepatomegaly, and peripheral edema with ascites are some of the cardinal features of this pericardial disease. Chest radiography usually show a globular enlarged heart with a pericardial calcifications in this condition. And when central nervous system is involved, in case of meningeal disease is most commonly seen. Tuberculous meningitis can be one condition. If untreated, it can become fatal. However, survivors are present with neurological sequelae also. And clinical features, coming to clinical features, they have vomiting, headache, depression, confusion, low-grade fever, lassitude and behavioral changes. Other oculomotor palsies can be seen. which can include papilledema, focal hemisphere signs, etc. Coming to staging of the severity, in stage 1 it is an early condition, stage 2 intermediate and stage 3 is late. In stage 1 we can see non-specific clinical features, usually unaltered consciousness in these conditions. In stage 2, which is an intermediate condition, we can see focal neurological symptoms, especially there can be slight alteration in consciousness without coma or delirium. In stage 3, it is a late stage where we can see coma, stupor, there can be severe neurological symptoms and seizures. Coming to bone and joint disease, usually it affects the spine and it is called as Pott's disease. In this condition, there will be paravertebral or psoas abscess formation, which is large cold abscesses seen in the inguinal region. Ponson's arthropathy can also be seen. It is a immunological mediated polyarthritis. Usually it results in 2 months after initial effect, after 2 months period of time of the infection time. This is called as Ponson's arthropathy. Now coming to the diagnosis, usually history and clinical examination with the chest X-ray will be helpful in diagnosis. Direct microscopy of sputum, that is acid-fast bacilli, especially which is positive for 5,000 to 10,000 grams can be seen. Gill-Nielsen stain and rhodamine auramine can also be useful in case of diagnosis. And this is a picture which is showing Gill-Nielsen stain showing Mycobacterium tuberculosis. Auramine acridine is a special stain which can be used for detecting tuberculosis in sputum, that is a Mycobacterium tuberculosis within the sputum. Here we can see the smear, stain smear, which shows a Mycobacterium tuberculum with a fluorescent color, fluorescent auramine with acridine. Other tests which are being used is tuberculin skin testing, where a purified protein derivative, that is PPT, is being injected into the intradermal. It will be injected subcutaneously. There are two types of tests. One is Heave test and Montauk's test. Heave test is usually given at 3 to 7 days period of time, and it is a multipuncture method. In this also what happens is purified protein derivative will be injected subcutaneously and it will be rounded off, it will be marked, and patients are usually observed after 24, 72 and 72 hours. If there is any erythematous region, then it is usually taken as tuberculosis after 72 hours, and Montauk's test is also been done after usually at 2 to 4 days period of time, and 10 tuberculin units are usually used for Montauk's test. Normally this Mycobacterium tuberculosis, it requires about 4 to 6 weeks period of time for to grow on a medium like LG medium, that is Lowenstein-Jensen's medium or Middlebrook medium, and radioactive BACTEC system can be used, but it usually takes about 1 to 3 weeks, and non-radiometric Mycobacterium growth indicator tube, that is MGIT, can also be used for growth of this, for growing this MTB. Nucleic acid amplification test can also be done for MDR-TB, that is multi-drug resistant tuberculosis, and in pleural fluid we can also see adenosine deaminase. By assessing this adenosine deaminase in the pleural fluid, Mycobacterium tuberculosis, it can be also one of the diagnostic tests for identifying Mycobacterium tuberculosis. When coming to management, normally the standard treatment for tuberculosis management is 6 months treatment with isoniazid for 6 months period of time, which is actually a combination isoniazid, rifampicin, and which is supplemented by pyrazinamide with ethambutol in first 2 months. That is in a new onset TB or extrapulmonary tuberculosis. 6 months treatment regimen is usually followed. When it is coming to meningeal tuberculosis or spinal tuberculosis, the treatment is taken for 12 months period of time, and here ethambutol is usually replaced with the streptomycin. So this is actually a picture which is showing various mechanism of action. For example, isoniazid and ethambutol acts on cell wall synthesis, and pyrazinamide usually acts on ATP synthesis, and our rifampicin will also act on the DNA system, that is on the DNA polymerase, preventing the replication of this bacteria, that is Mycobacterium tuberculosis. So these are the various mechanism of action of these drugs, thus preventing replication of Mycobacterium tuberculosis and its activity in the disease progression. Now coming to pregnant women and malnourished women, malnourished kids or any malnourished people, patients, normally pyridoxine has to be given. Here isoniazid is being replaced with pyridoxine because isoniazid is known to cause peripheral neuropathy. Coming to rifampicin, the side effect of rifampicin is usually they have bright orange red tears, urine red in color, and other secretions also will be in orange red in color. So patients has to be told prior itself not to worry, because it is usually a side effect of rifampicin, and hyperbilirubinemia is one of the side effect of rifampicin. Coming to the effectiveness of therapy, how do we check whether the effectiveness of therapy is? Sputum smear is usually done after 2 months and after 5 months of therapy. After cessation of the therapy, after 2 months and after 5 months also there will be sputum smear done. If the sputum smear is negative, then the treatment is said to be effective. Now, coming to drug-resistant tuberculosis. In recent days, drug-resistant tuberculosis has become a main headache to the physicians, because there will be presence of resistance to any first line of drug. So, it can be because of drug shortage or poor quality of drugs, no apt supervision, or drug resistant strains have been developing, or patients already have taken prior treatment and hence they have developed resistance towards this treatment. Whatever the may be the cause, then this usually drug resistant tuberculosis is one of the potentially difficult cases to treat. Normally, multi-drug resistant tuberculosis is resistant at least to one drug, that is at least to rifampicin and isoniazid, they show resistance. In extensively drug resistant tuberculosis, MDR in addition to quinolone and at least one second line drug, they are resistant. This condition is resistant to these drugs. So, to prevent this resistance due to no apt supervision, or because of drug shortage, or because of non-compliance of patient to such drugs, what they have done is there is something called as directly absorbed therapy, that is DOTS. Here they will be having a supervised administration of therapy 3 times weekly to improve the adherence of these drugs to the patients to these drugs, or increase the patient's compliance. And there is also certain vaccines which have been present to prevent tuberculosis, that is live attenuated vaccine from Mycobacterium bovis. The vaccine is BCG, that is the calmatic urine bacillus vaccine. This will be helpful in preventing tuberculosis, and by giving this BCG vaccine, what happens is we can prevent further attacks of tuberculosis in future period. So this is about tuberculosis, various organisms that have been involved in causing tuberculosis, etiopathogenesis, and how it actually involves the lungs, that is the primary pulmonary tuberculosis, post-primary pulmonary tuberculosis, and we have seen about extrapulmonary tuberculosis also, which includes lymphadenitis, lymph node involvement, bone involvement, spine involvement, and other liver involvement also have been seen in these cases. So, and we also have seen how management of this has to be done with the help of first line drugs and second line drugs and other drugs that have been helpful in treating tuberculosis. So this is about tuberculosis. Thank you.